Good evening, ladies and gentlemen. Welcome to another of the University of Manitoba's Café Scientifique. My name is Dr. Michael Moffat. I'm a pediatrician myself, and with a few gray hairs, and also somebody who's worked and practiced in community health sciences over the years. I'm going to be your moderator for this evening. We have a really interesting and dynamic panel. I don't know about you, but a lot of people, when they hear about another child being injured or killed in a traffic collision, or on a bicycle, or a fall, or even in a situation of domestic violence or aggression, they often think, oh well, terrible thing, but just these things just happen. But I think you'll hear tonight from our panelists that there is an awful lot more science and an awful lot more systematic learning that can be had about injuries. And not only that, but there are many places in the world that have applied that in a much more diligent way than we have in the province of Manitoba or in Canada, with really significantly more successful results. So I'm not going to hog the microphone. I'm going to pass directly to our panelists, all of whom are doing some really interesting and innovative research and knowledge translation in the area of injuries and injury prevention with respect to children. Our first panelist is Dr. Lynn Warda. I've known Lynn since she came here as a resident a few years ago, a couple. She's currently the medical director of IMPACT, which is now the injury prevention program for the Winnipeg Regional Health Authority. She's also a pediatric emergency physician at the Children's Hospital. So if you've taken your kids to the Children's Emergency, you might have seen Lynn, and one of our other panelists, Carolyn, as well. And she participates in teaching and research at the University of Manitoba in the Department of Pediatrics and Child Health. She received her medical degree from McMaster University, and then she came to Manitoba to do her pediatric residency at the University of Manitoba, and subsequently also studied in the Department of Community Health Sciences and took a PhD degree, and has been practicing and researching injury prevention and working on program development at IMPACT. Her research includes studies of helmets, booster seats, parental supervision, childhood poisoning, and sudden infant death. And she's been a member of many national and international injury prevention committees and has contributed to policy statements, publications, and book chapters on child injury prevention. She's also enjoyed participating in policy development, working with governments and health authorities and others. So without further ado, Lynn's going to talk about the whole field of injury, unintentional injury specifically.
All right, so I'll try to give you a little bit of an introduction so we know what we're talking about, because sometimes people are a little bit confused when we start to talk about injuries, because there's chronic injuries, acute injuries, workplace injuries. So what is it we're talking about? Well, today our focus is on children, and we're going to talk about unintentional injuries, or so-called accidental injuries, but we don't call them that anymore, because of course they're preventable, and intentional injuries. So those that are inflicted by oneself or to another. So we're going to talk about the whole spectrum, but concentrating on children and youth. So just reflect into your lives, home, workplace, otherwise. All of us, I can guarantee you, and I'll be shocked if this is not true, have experienced an injury in our lives that has required some sort of medical attention, whether it's a fracture, a burn, being involved in a motor vehicle collision and having whiplash, lots of things. So they're very, very common, but they're also very serious. So injuries are actually the leading cause of death for Canadians between the age of 1 and 44. Suicide is sort of upticking basically, and is overtaking unintentional injuries in that last age group, but combined they're still the leading cause of death. Infants under the age of 1 also experience high rates of injury, but other things, perinatal conditions, things they're born with, congenital problems actually exceed injuries in that age group. In terms of how common they are, in children, at least 1 in 10 children, if you ask their parent for the last year, would have sustained a significant injury. And amongst all Canadians, actually 15% of Canadians, if you ask them, and these are countrywide surveys, that they have actually experienced a significant injury, enough to avoid work for a day or two, or to see a physician, or to interfere with their daily activities. So very, very common. In terms of numbers, there's over 200,000 Canadians hospitalized every year for injury. Over 15,000 suffer a fatal injury. So very significant burden across our country. In the emergency department, this is an extremely common reason for children to come to the ER. In some studies, up to 30% of all children and 40% of youth who come to emerge are actually there because of an injury. So in children's emergency, the last we looked at the numbers, there's about 8,000 in a year. So that's a huge number, and a whole range of things. You can imagine walking through a child's life from birth on upwards into the teen years, the causes of injury actually vary quite a bit over the years. So infants tend to be more injured in their homes, and depending on what the hazards that they're exposed to, they're dependent, of course, on their caregivers and whatever they have access to. And as they develop, they become at risk for falling, off beds and downstairs, out of windows, ingesting things, putting things in their mouths they shouldn't. You move then up into the school age years, and they're out on the roads, so they're starting to be hit by cars, whereas they were protected from that previously in their homes. Bicycle injuries, playground injuries, and then we start to get the interactions between peers, siblings. So some of was it unintentional or was it intentional, or sometimes we just don't know. Some of the intentional injury starts to creep in. Not that it's not completely absent in the younger kids, but certainly becoming more common as they get older. Into the teen years, they're now drivers and driving with their friends. So all the risks of young drivers, exposure to alcohol and other substance use can often result in injury, both so-called accidental and also intentional. So again, resulting in conflicts between youth. So again, very, very common, but quite a range of different things that lead them to actually become injured. Some raise the question of whether certain individuals are injury prone. So you might even sort of talk about that. It's a pretty common thing in your day-to-day life, is that you're clumsy, and other people seem to escape injury more than others. And there is some truth to that, but when you analyze it, there's actually more systematic reasons for it. So for example, boys are at more risk for injuries and more severe injuries than girls. And so Caroline has done some work on that, and maybe we'll touch upon those gender differences that do have influences on injuries. Age-related risks obviously can also, you can't modify your age, but there's different patterns by age group. But there are individuals who, when we looked at our database, it's up to 15% of the children in our injury surveillance database are in there more than once, and some of them up to 15 times. So like these are, there's a subset of children who tend to have recurrent or repeated injuries, both intentional and unintentional. Then when you look at families, the same is true. So there's a number of studies that have looked at injuries within families, and there does tend to be a clustering of injuries, so a higher risk. Again, a mix of intentional and unintentional injuries. In terms of the other risk or sometimes protective factors, income definitely comes into play, and the impact on education and housing and other hazards in the environment that certain individuals and families are more exposed to simply because of those socioeconomic differences. So there's real disparities in injuries with high rates in certain geographic areas and in certain population groups as opposed to others. So can we prevent injuries? Well, I'll give you two scenarios. One, a toddler falling into the backyard pool and drowning, and a basketball injury with a basketball player with an ankle injury. Some would argue that the child drowning is definitely preventable. I mean, there's so many things you could do to prevent that injury. Others would argue that the basketball injury that's just part of the game. When you're playing sports, you're going to get a sports injury at least, every once in a while, hopefully not repeatedly. But there's actually science behind all kinds of injuries and their prevention. So there's many, many individuals, well-designed studies, as well as groups of studies or systematic reviews, even whole books and book chapters about how to prevent different types of injuries. And so what has been done is an analysis of all the factors that lead to injuries, whether they're at the individual level or the environment around them. And so we actually know a lot about preventing injuries, and most of them, in fact, are preventable. There's also some evidence when you look to history, so injury rates have actually reduced quite significantly over the last 40, 50, 60 years. Injury is still the leading cause of death, so we have a lot of room to move in terms of further reductions, but the rates really have reduced, and there's many interventions in our society and in design and manufacturing and in consumer products that have actually resulted in those declines. Things are just basically safer today than they were 50 or 100 or 150 years ago. We can also look to other countries, both who have higher rates and lower rates. So there is a very system that actually protects the individual from that injury. The other thing we can learn from these larger scale disasters is that policy changes and things that you can consider to be more sort of passive, in other words, not affecting individuals' behavior, are actually far more effective than trying to change everybody's behavior. So it would be great if everybody would, drive under the speed limit, not text and drive, wear their helmet, wear a PFD, all kinds of things that we know are effective. But to change everybody's behavior is near impossible. Well, it is impossible. So we need to rely on other measures that are more systematic or at a systems level. So policy changes, building design, road design, product standards, the design of products, cars, etc. These are all the things that we don't have to really think about. You can choose a product that's safer, or a vehicle, or a home. Ensure that there's a functioning smoke alarm, but if the building code requires it and it's just there, then you don't have to really think about it. So we try to put our efforts into the things that are going to be most effective. However, there's a balance between using different types of strategies, and where it's actually so ingrained in injury prevention, what's called the 3 or the 4 E's. So E, the first E being education, not so effective, but we still need to have certain types of education. Enforcement, so that relates to laws, policies, etc. Engineering and environment, so those are those engineering changes, so improving a product, improving road design, speed bumps, speed humps, things like that. And then others introduce an economic measure, so economic incentives and disincentives, such as MPI. When you are not such a good driver, your rates are higher. Home insurance, your rates reflect certain safety features in the home, how it's building construction, age, etc. So in other words, sort of monetary ways to influence people's behavior. So finally, I'll just wrap up with where I see some gaps. We know a lot about preventing injuries, both at the individual level and even when you look at these larger sort of disasters. But we haven't completely applied everything that we know. So that's the first major gap. The second would be we still see these huge disparities in injury. And so that really is a place that we really need to maybe even do a little more research about what can work to reduce those disparities. And then finally, there's some new and emerging issues. And this is just, life. Society is evolving, technology, etc. We're becoming very, very busy. So what I call lifestyle issues. So the busyness of our society, I think, really contributes to the rates of injury. So the texting and the rushing, even some falls, I think in seniors and in ourselves, can be related to that rushing. And technology is also definitely contributing to some injuries. There's some new trends in poisoning. So you've probably seen it, it's been in the news a fair bit in the last year or two about the potent narcotics such as oxycodone, overprescribing, and how it's resulting in exponential rates of rise in injuries of all ages, little kids, adolescents, and even adults. So that's another emerging issue that really needs some more attention. And I'll leave it at that for now.
Thank you, Lynn. That's a great way to get started. I'm going to move to our far right next. So our next speaker is also an emergency physician, Dr. Carolyn Snyder. She's an assistant professor in the Department of Emergency Medicine, and she's a scientist with the Manitoba Institute of Child Health. She also completed her medical degree at McMaster and did a Master's of Public Health at Johns Hopkins Bloomberg School of Public Health in Baltimore, and her emergency medicine residency at the University of Toronto. Before she moved to Winnipeg in 2011, Dr. Snyder practiced at St. Michael's Hospital in Toronto. She's the chair of the Trauma and Injury Prevention Committee for the Canadian Association of Emergency Physicians, and she's on the board of the Society for the Advancement of Violence and Injury Research. Dr. Snyder's primary research focuses the design, implementation, and evaluation of interventions for preventing youth violence. She does what we call mixed methods research, and I think she's going to talk to us about some of her research programs. She's also the medical director of the Winnipeg Health Sciences Centre Emergency Department Violence Intervention Program. She's been funded by the Canadian Institute for Health Research, Manitoba Health Research Council, and the Manitoba Institute of Child Health, and Manitoba Medical Services Foundation, and the Winnipeg Foundation. Carolyn?
Thank you. So I hope to only take a bit of your time today, but hope that we'll be able to have more discussion afterwards around injury. Often it's a bit of a stretch for people to be sitting hearing about unintentional injury or childhood injury and then to quickly switch to youth violence or assault or suicide. And I think though it's happened over the last number of years in Canada and the last probably few decades in some of the other countries like the United States that are perhaps a bit more advanced in terms of the research around injury, is acknowledging intentional injury as a health problem. And so often when you think about things like assault or child maltreatment or even suicide, people see them as truly not something that we can prevent, that it's in a different realm, it's not within the health realm. And as we reframe our focus and acknowledge the impact it has on our health system, but also that a lot of the answers can be found in our health system, and that a lot of the frameworks that we've used to look at unintentional can be used to look at intentional injury. We've started to really work together as injury professionals. And so I, as an emergency physician, got involved in this because very early on in my residency, I met a number of young people. And at that time I was at Sunnybrook in St. Michael's in downtown Toronto. And I met a number of young people who were injured by violence. And a lot of what I had learned about violence as somebody who had grown up in a middle-class neighborhood, not really exposed to a lot of violence, came from these young people, these individuals. And what they did, or sorry, prior to that, had come from the media. And what these young people did was really challenge those views that I had had ingrained in me through the media. Many of them were some of our politest patients. Many of them had very, very loving families. And a lot of them were quite interested in their future. And that was a bit of a surprise for me, because that's not what I expected. This isn't what the TVs showed me. And so it really spurred my interest in these young people that I was seeing commonly in our emergency department. And so I'm going to speak now a bit broader, and I'm going to get back to the individual. I passed around, and if you came in a bit later, you might not have a chance to see it, but there's a framework that's used often in injury talks as one of our first slides. And it talks about the leading causes of death. And I think Lynn really did a good job of setting up that it's such a huge impact on our healthcare system, and we don't actually talk about it enough. It's one of the most underfunded areas of research in Canada compared to the number of deaths that actually that it affects. But death is really just a tip of the iceberg. So for me, I know the stats on youth violence. That's sort of my home research area. So for every youth homicide in Manitoba, we see approximately 50 admissions to hospital and approximately 400 ED visits, emergency department visits. And what does that mean is that it's much, much more common than I think we hear about, because most of the time when you're hearing about youth violence, it's in the media and you hear about a homicide. And sadly, putting that into even closer numbers, at HSC, between the adult and the health science and the children's emergency department, we see approximately 1,000 youth visits for an assault every year. About 20% of those youth will come back with another visit due to violence in the next year. This is a chronic problem, and we need to focus our mindset on how these happen, and so start looking at it in some of the same frameworks we look at other chronic diseases. And so I'm going to take you into a bit of some of those, one of those frameworks that we use, and that's known as the ecological framework, and it comes out of the CDC and the WHO. We look at a number of injuries, a number of health problems that way. And so I'm going to do my interpretive dance of the ecological framework. And that is really a set of concentric circles. So you have your individual, and then you have your relations, and then you have your community, and then you have society. And you have to think about injury, and we do that with intentional injury a lot, on each of those different levels to understand how they happen. So individually, we have a lot of risk factors for intentional injury. We have age, we have gender, we have substance use or a history of child maltreatment, all put somebody at higher risk of intentional injury. Interpersonal, so a sense of belonging, relationships with peers or broken down relationships with peers, relationships with parents, relationships between parents. These are all high risk factors. In the community, so even if you have if you have a strong individual and you have a strong family, even being within a community where there's a high crime rate puts you at higher risk of that. And we look at social norms with that community. And finally, when you look at social policies in the outer circle, you look at social policies around education and economic social policy as well as health policy. These are all very important and cross all of those areas of intentional injury. And so we look at preventive measures, both at each of those levels. So individually, we look at ways to build that individual and to change behaviors. In relationships, we look at peer-to-peer relationships. We look at relationships with families and family counseling and conflict. As we get higher up, we look at community, and this is a really interesting one, and if you get involved in the community in Winnipeg, there's a lot of people working hard at this, but that's community efficacy, and that's around changing what's the social norm and what's okay in our community. And we've seen a lot of that in the last number of years, that people have said, this is not okay, we have to make change so that our young people are safer. And finally, in society, and looking at changes in policies that will keep our young people safe. And so, although I'm grouping a whole bunch of different types of injuries within the realm of intentional injuries, there's slight differences between each of those. Clearly, suicide and self-harm within that intentional injury has a genetic component. It has a number of components that also go into that. Youth violence, we have a number of inequities and key things like safe housing, which is a big issue here in Manitoba, around a bigger risk factor for that. And so I wanted to spend the last little bit of my little time just giving a taste of some of the research I'm doing around that here in Winnipeg. The first, I believe that injury has to be looked at different levels, and so I really have two areas of my research. One of them is on that population level, and right now, and hopefully within the next year you'll hear about it if it comes out as exciting as I think it will, I'm looking at a multi-level analysis. So when we talk about a young person's risk for severely enough to be admitted to hospital, we look at a number of those risk factors. So we're actually able here in Manitoba, unlike most places in the world, I would say, to link our health number to a number of social registries. So it feels a bit scary, but I can promise you, given how long it's taken me to get this through, your data is very, very safe. But on a large level, all of your PHIN numbers, your population health numbers, are linked to your education. So if I had grown up here, you could link my current health information to how I did in grade 3 and grade 8 and grade 9, whether I finished high school. It's linked to my interactions with the justice system. It's linked to the income level of the communities I've lived in, the income level of my family. Now, that kind of sounds pretty scary. And yet, what it allows us, because there's so many safeguards in place, is to create an amount of knowledge that is so incredibly important and comes from Manitoba, and we should be incredibly proud of it. So we're doing that with intentional injury, and we're looking at both the individual level and the neighborhood level, and how we can look at neighborhood changes that could, level changes that could impact the individual. The other area of research is on an individual intervention. And as I mentioned, 20% of youth who are coming through our emergency department injured by violence have been there in the last year. And as a result, we're trying to capture that youth at the time of the initial visit to try and prevent those repeat visits. And so we have a program now at HSC called the Emergency Department Violence Intervention Program, also known as the EDVIP or EDVIP. And we have young people being met in the emergency department at the time of their injury by a support worker. These support workers are all people who are highly trained and have great experience, both personal experience but also working with other young people out in the community. And they'll work with that youth for approximately 1 year, sometimes less, sometimes more, on the key issues that that youth has identified that puts them at risk of violence. For a lot of them, it's safe housing. I cannot stress how important that is of an issue that we need to deal with here in Winnipeg and in Manitoba. For a lot of them, it's family conflict, and we work through a lot of family counseling with them. Many of them, it's education, and I'm proud to say that of the over 55 that have enrolled in our program since last November, a huge number started school last week. Substance use, a major issue. We have an addictions counselor on staff that's going 24 hours a day, and we've got a number of resources in the city to help young people, but we need more, and we need better and quicker access. For when a youth is ready to change, they need to be able to have access to that now. In fact, that goes for all ages. And so that's the kind of work we're trying to do from an individual level, and we hope to be able to show that those interventions, albeit expensive and intensive, make a big difference on our healthcare system. If we can prevent a major injury, an admission to hospital, we can make this all cost benefit, and obviously it's not all about dollars. It's about the societal cost, the individual cost, and the long-term cost. So I'm happy to talk more about those. And I should also mention access to mental health, which fits into this. There's a lot of overlap with our young people who are injured by violence by someone else, and suicide and mental health. And access to mental health resources in our city is a common challenge, and something that I would love to see improved. I think people would say that across Canada. But access, when somebody's again ready to change or is asking for help, we need really, really good help. So those are some of the key things that I'm working on, and happy to talk more about that later.
Thank you, Carolyn. We've transitioned from the unintentional injury to the topic of violence and intentional injury. Our next speaker is Dr. Carolyn Piotrowski. She holds a PhD and a Master's in Public Health. She's an associate professor and the head of the Department of Family and Social Sciences at the University of Manitoba, and a scientist with the Manitoba Institute of Child Health. She holds a degree in Human Development and Family Studies, Health Promotion, and Developmental Psychology. She was also a Violence Prevention Fellow in the School of Medicine at the University of California, San Diego, from 2002 to 2004. Caroline's areas of expertise center around injury and violence prevention in the family. She has a particular emphasis on sibling relationships and the effects of trauma on children. Over the course of her career, her work has examined family conflict, the effects of exposure to intimate partner violence on siblings and sibling violence. She is particularly interested in family factors that mediate the risk for violence and injury. Recently, she's investigated risk factors for child injury at home, including parent and sibling supervision and sibling conflict and harm. She's collaborated with provincial and national research teams, including the Child Automobile Safety Fund, funded by Auto 21, and the CIHR team in child and youth injury prevention. She's a founder of the Violence and Injury Prevention Research Group at the University of Manitoba. Caroline?
I'd also like to welcome all of you this evening. Violence and injury are very dark topics for a lot of people, and a lot of people prefer to avoid listening about it and talking about it. So we really appreciate your interest in being here tonight and in joining us in our conversation. My final comments after hearing about unintentional injury, what most people call accidental injury, that no one meant to happen, just kind of did, but as you've heard, it just kind of happened at all. And inflicted injury, or violence as we most often call. Most of the time, these two things have been studied very, very separately by very, very different people who hold separate conferences, who publish in separate journals, who occupy separate departments at universities, and who very often don't have very much to do with each other, ever. And that seems a little weird, increasingly weird, and that is a technical term, because we have noticed more and more over the past decades that when these people talk to each other, it makes a huge difference in stopping people from getting hurt. And that's what we all want to do, whether we're on the medical side of the equation, the social science side of the equation, or any side of the equation. We all want to stop people from getting hurt. And the question becomes, how do we best do that? So when injury researchers, whether it's intentional or unintentional, talk to each other, they start to realize they have a lot in common in terms of what they're studying. And the first thing they realize is that it's not always as clear-cut as you might think. When someone does get hurt, it's not always super clear. Was that unintentional or was that intentional? A car crash, for example. Single vehicle, single occupant car crash. Did that car go off the road because of road conditions? Or was that a person who was depressed, who was suicidal, and who was using substances, and that's how they chose to kill themselves? It's not always clear in the field of violence and injury exactly whether the intention was clear or not. But when we get together and we start having these conversations, and it's kind of a wonderful phenomenon that this is happening more and more, we begin to see how much these two areas have in common. And as soon as we do that, our chances of stopping people from getting hurt get better. Why? Because we identify ways that we can work together. Whether you're in the field of justice and policing, whether you're in the field of education, working with kids in elementary or high school, whether you're in the healthcare field, such as emergency or family physicians or home care workers or nurses who visit people's homes. There's all kinds of ways that when we work together, we can stop people from getting hurt by identifying the things that increase the chances of people getting hurt. And you've already heard a little bit about that. Mental health is huge. Mental health is a huge shared risk factor. It means it's more likely people will get hurt when they have a mental health issue. Depression is a great example of that. Depressed people, and we're talking serious depression, are far more likely to fall, far more likely to experience different forms of injury. They're also far more likely to experience violence. And that's a circular risk factor, meaning that after you've been injured, of course you're more likely to feel depressed, especially if it's a serious injury. And of course, if you've experienced a violent incident, whether it's a random violent incident on the street or whether you're in a violent relationship, you're also more likely to be depressed. And you can see the circular causation there. Trauma is highly related to that. And so there's a big relationship between psychological trauma, meaning something has happened to you that has had a profound impact that is lasting on you a long, long time. And I think we've all heard of PTSD, which is one of the most serious forms of trauma, and how that's related to physical trauma. Are you more likely to experience both violent and unintentional injury if you've experienced trauma? Yes, for sure. So these shared risk factors help us to identify people that are more likely to get hurt, and it helps us to then put prevention programs in place to help reduce that likelihood of getting hurt. You've already heard from both substances, and especially alcohol is huge in terms of both unintentional injury, where someone is drinking and driving, and we all know that this is a serious problem, it continues to be a serious problem, because it's not only the person behind the wheel who has been using alcohol who's going to get hurt, right? If they have a car crash, it's the other passengers in the vehicle, whether they've used alcohol or not. It's the other drivers on the road, whether they've used alcohol or not. It's the pedestrians, it's the cyclists. So, and same with violent injury. People who visit emergency departments or who are arrested because of violence are far more likely to be using either alcohol or illegal substances. So that's another shared risk factor where we know if we can do something more about that, we're going to reduce the chances of people getting hurt. And the tree agrees with me. So by exploring more and more what the shared risk factors are, and the comment was housing is huge. Of course it is. And unsafe housing is unsafe for lots of reasons. If you're living in buildings that are run down, you're more likely to experience unintentional injury as well. The stair gives way.